Everybody. My name is Carolyn Dubé and I'm the Executive Director at Fertility Matters Canada. And we're here live with you tonight on Facebook and Zoom with Dr. Ari Baratz from Create Fertility. And Dr. Baratz is actually the brand new Vice President with Fertility Matters Canada. He's a huge supporter of Fertility Matters and an excellent provider of patient-centered care. Dr. Baratz, thank you for being here tonight. We're going to talk all about the brand new COVID-19 vaccine. It's rolling out across Canada, and patients and individuals in this country and probably globally have questions about what this new vaccine means for people who are pregnant, people who are planning pregnancy, people who are considering starting fertility treatments. So I'm thrilled to have you here tonight to kind of put things in perspective and talk to us about what we know so far.
Thank you, Carolyn, for the introduction, and thank you for being a platform for these kind of discussions. I know that one of your main goals is to be a premier voice for advocacy for Canadian fertility patients and fertility patients across the world. I'm sure there's many people outside of Canada that are watching this, and so having these timely talks are very helpful. And I know that myself and my colleagues are always happy to provide time for this discussion. I hope that one day we won't talk about COVID anymore, and it'll be part of the vaccination schedule for people, and it won't be something that we speak about in terms of risk and benefit, but just benefit.
Absolutely.
So you mentioned perspective. I think it's very important that we discuss where we've come over the past year. So about a year ago, something happened somewhere in the world, and it completely put COVID on the map. And we don't know the full nature of the mechanism, but a new virus that started in the animal species moved to human and has now killed 1.7 million people, has affected pretty much every country in the world. Closer to home in Canada, we've had about 500,000 cases. We've been fortunate to have only 14,000 deaths, although those are critical lives. And we've learned a lot in the last year, but it's been a very painful lesson. So I think that just sets the tone that this is still a timely conversation. I think what's also interesting is that a year ago, the concept of anything other than social distancing and masking and advancements in respirator technology, we really had no idea how we were going to deal. And the vaccine was really a pipe dream. It was something that was so far away that it was talked about. Even the experts were saying 1.5 to 2 years, and now we're inside a year and we're ready to roll it out. So I think that's a great starting point. I'm happy to, all the areas you discussed, I think are relevant. So people who are, let's just go through the whole spectrum.
Yeah.
People who are planning to conceive, people who are in their first, second, third trimester, people who are lactating, all of these people, and just women who are even pre-conception, like not even sure how they should map out their family. All of these people are on the sort of docket for tonight. I'm happy to kind of move in whichever direction you feel most appropriate.
Okay, so before we get into everything, if you're watching live, no matter where you're watching us from, if you're on Zoom, please, if you have questions for Dr. Baratz to answer, put them in the chat option. If you're on our Facebook Live event, just put them in the comment section. I'll be checking through my smartphone to have your questions answered live tonight. So why don't we start with what we know? This vaccine is here. And people are rolling it out. What do we know about the vaccine in general?
Okay, so let's start with what we know. Not much. I mean, that's one of the bottom lines, because even though many people ask, how is it possible a vaccine that was essentially thought up within a year, and vaccines typically were 5 to 10 year long projects, was able to be launched and rolled out? Like, how is it that we're talking about how to load the planes and how to store the vaccine when it was just thought up a year ago? Exactly. And so people have to realize that this was a worldwide effort. Even though there are separate companies that have developed vaccines, there was a lot of coordination that went into this, massive investment. So when you hear about the Canadian or US government or whichever organization sponsoring or funding vaccine development, what they essentially were doing for the most part was not so much just the vaccine development, but they were front loading the production. So the reason we have so many doses ready to go is because the government said, look, we're going to pay for it, whether it works or not. We're going to help you develop it, and then hopefully the trials will support it. So I don't want people to misinterpret the actual safety of the vaccine. Like the vaccine in the non-female pregnant fertility population has been studied adequately, has gone through all of the rigors of any classification. And the bottom line with the vaccine in almost everybody is that the benefits of the vaccine far outweigh the risk. So I mean so anyone that's not female, anyone who's not trying to conceive, pregnant, lactating, your group or your population has been tested, and I think those are people that should actively consider the vaccine, because you may be close in contact with the people who we're interested in this evening. Another really important point to recognize is that there's two goals for vaccine. Vaccine number one is to reduce the experience in you, or one of its goals, so that if you were to contract COVID, you would not be as sick, you would not end up in the ICU, you would recover more rapidly. But the other goal, which is a little bit more difficult, is it going to reduce transmission? So are we going to be able to achieve both goals, reduce the effect in an individual and achieve some kind of herd benefit? And I don't know if we fully evaluated the second aspect of it. So that's why it's really important, whoever is listening to this, that if you do receive the vaccine, you still need to mask, you still need to follow all the distancing protocols, and that's not going to be replaced for a while, because this rollout that we're discussing is at least year-long rollout, right? I mean, the first doses are coming out now, and I think by Q2 of next year, they'll have a certain percentage. It's not till the end of next year that they'll have kind of the mass population. So in terms of what we know it's safe to give to the average person, and we know that, in fact, people who are sicker do better with it through the trials. But what we absolutely do not know for sure is what happens in the pregnant female, right? Because pregnant women were excluded from all the studies. Some of the trials had incidental pregnancies, a couple dozen pregnancies that are still being followed but were removed from the trial. And certainly there was exclusion for anyone that was attempting fertility treatment or any one of the population we're discussing. So we're not flying by the seat of our pants per se, but we're talking a lot of hypotheticals and theoreticals.
Got it. So with these, I mean, I know that there are people in Canada who now have been, or at least received the first dose of the vaccine. Some of them will be frontline workers like yourself, depending on where they work within the hospital systems, for example, or paramedics. So what are we telling patients if you're considering and or pregnant? What does a patient do?
Well, it depends where you live. Like right now, I mean, the two best examples that we use is what we're telling people in Canada, and we're closely following what our American brothers and sisters are doing, and similarly to Europe. I think those are the three biggest jurisdictions for advice. Also, I would say Europe, the US, and Canada have followed their cases very closely. I mean, we're generalizing here, but what's interesting, and that's one of the reasons we're talking this evening, is that some of the statements that have come out of the American Society, the Reproductive Society, the Obstetrical Society, and some of the other affiliates have been very pro-vaccine. In fact,
and we're talking the US here.
We're talking about US, yeah, we're talking about US, like the American affiliates, including some American, European affiliates, have been very pro the vaccine. And they've come out and emphatically said that there should be no discrimination of any access to the vaccine for any female, regardless of age, whether they're in the reproductive age, outside the reproductive age, pregnant, lactating, fertility. There should be no discrimination. They do also make the comment that it should be in discussion with your physician, but that should not be an exclusion, and that even so far as to say that a pregnancy test is not a requirement. So the American adoption of vaccine rollout for reproductive age people is very high. And in fact, the only real big barriers right now are some of the, I would say, fake news or false news that's circulating around potential impact on fertility and pregnancy, which is, with at least the mechanisms that are postulated by these anti-vaccination people, is not true. So that's American. Canada has sort of stopped short of that, and our Canadian Fertility Andrology Society, Health Canada, the SOGC has not, the Society of OBGYNs of Canada has not come up with a formal statement yet, but is very close to that. And they've all said, you can get it, but we're not advocating it. And you need to discuss this with your doctor. But it's certainly falling short of where the American position is.
Yeah, it's quite interesting as I've been reading over the past couple of days. And in speaking with you and getting my information, it's quite different what's coming out of the US and what they're recommending versus what Canada is recommending for patients.
Yeah.
So,
well, what I find interesting, I mean, there's no question that when you look at the highest risk people, so people in long-term care facilities, frontline workers, well, long-term care facilities are usually, I mean, that's a mixture of people because it's typically people over 60, over 70. So we know those are the highest risk individuals, and the vaccine is mostly targeted to them at this point. But the problem is their care providers, many of them are female. In fact, a high percentage of them, and many of them are in the reproductive age. And so they're the ones that we're still really, at least in Canada, moving away from, whereas in the US, it's being advocated for. So, it's one of those things where does the risk lie and where does the benefit lie? So what's interesting is that when you look at adverse effects in these trials, they were very minimal, even though they weren't formally studied in the pregnant population. And the other thing too you have to think about is the mechanism of action. So in some ways that's not really reassuring to people. It's nice that, oh, this is a new technology, therefore I should be taking it. But if you really think about the biological action of these new vaccines, meaning they're generated from a different part of genetic material. They come from RNA. So RNA is not DNA. RNA is what our bodies use to generate proteins, but it's not how we code the protein. So meaning it doesn't affect our primary DNA. It doesn't cause mutations. Well, it does influence the cell because it's that we use the cell to produce those proteins. So essentially what the vaccine will do, the mRNA vaccines, is they'll give the instructions to the cells, make this protein, and that protein happens to be one of the hallmark proteins of the coronavirus, the spike protein. And it's that very spike protein that when we produce it through the vaccine, without getting COVID infection, we're sending a message to our antibody system, which is part of the army, or part of the tools of our immune system, to be ready for a COVID infection. So normally you have to get the infection to develop immunity or potential immunity. What we're doing here is we're saying we'll give you the tools without the infection. That's how vaccine technology works. And using mRNA reduces side effects. It reduces that theoretical risk of actually getting the infection, because traditionally vaccination programs involved partial virus or dead virus to trigger the immune system. And you can think if you're giving someone partial virus or dead virus, maybe that virus can come alive inside of you. So the new vaccines are not related to that, at least most of them. Some of them are developed on the old technology. I think that's another important point, is that right now we're talking about 2 to 3 commercially available vaccines, but there's dozens and dozens of vaccines that are coming down the pipeline, and we'll probably have to have this conversation again, because as their safety and as their FDA and Health Canada approved, we'll have to reconsider them.
Absolutely. So it's incredibly complex and obviously challenging for anybody who's in this reproductive age, whether or not they're struggling with fertility or considering fertility treatment or pregnant. This is challenging. It's also challenging for you as a medical professional and those advising patients, because as Fertility Matters we're not a medical organization. We highly recommend that anybody in Canada has this discussion with their primary care physician, the reproductive specialist, to make sure you understand all of the information that we know and have. So do we know for women who are, for example, on the front line, is the vaccine going to be mandatory? Do we know any of that yet?
I mean, these are,
it's a loaded question.
Yeah, it's a loaded question. I certainly think that frontline healthcare workers, I mean, look, vaccination is still an autonomous event, like meaning the patient autonomy is the premier ethical principle that we subscribe to, and employment or working cannot be restricted to vaccination. I mean, obviously you'd still have to be using protective equipment, but the question is, going back a step, how bad has COVID really been for most of the population, including the pregnant women?
Mm-hmm.
And so that's sort of the saving grace, is that even though we've had deaths and we've had tragedy, most people, it's flowing through them. And
Mm-hmm.
I think our strategies, both on the social level, municipal level, provincial, federal, school closing, essentially locking down, has helped us. And also those that have actually been affected, most people have not been doing that badly. So the argument could be, well, especially reproductive, we're not seeing COVID severely affect fertility or miscarriage or babies. Really, the only group that has been subtly affected is, we know that if you're pregnant, or if you have COVID and you're pregnant, you're probably worse off than if you're COVID and not pregnant, which has scared many people because they're planning their pregnancies around that fact.
Of course.
We have to also realize that if any pregnant was to receive any kind of pneumonia or lung infection, they could get very sick as well.
Mm-hmm.
So
So pregnant women are more at risk for more severe illness. Is that correct?
yes, they are. But pregnancy in general, that would be applied to many different areas
Of course.
of health, not just of respiratory infections. They are at more risk for infections in general. Pregnancy is an immunocompromised state. And so the question, how devastating has that been?
Mm-hmm.
And certainly there have been pregnant female deaths,
Mm-hmm.
but the rate at which that's been happening has still not been overwhelming.
Okay.
So we're not telling women to stop building families. We're not telling them to stop trying to conceive. In fact, the main reason why fertility clinics were slowed down or shut down in the early phase of the pandemic, so like sort of mid-March to mid-May, was partially unknown, but primarily just to shunt care towards the critical areas, like not to
Mm-hmm.
exhaust the PPE, not to flood the system with early pregnancies if we had a problem. But in terms of safety, we're not, like, there's been quite a few reviews. In fact, actually, our group, the Create Fertility group, published a review looking at many aspects of fertility care, the penetration into the gametes, like egg and sperm, any transmission through the IVF process. And it's really, there aren't a lot of studies, but we're not seeing a major uptick in that.
Okay.
So I think the message to many people is, if you're still unsure about the vaccine, that's fine, but you should be as comfortable as you can be proceeding with assessment, diagnostics, and actually getting pregnant.
Okay, great. Do we know that if someone contracts COVID, does it affect future fertility? Is that something we know yet? Sperm production?
Right. So that's a good question. It looks like, COVID does make its way into the testes and into the ejaculate. We can find, they found viral particles in every fluid, like semen, blood, vaginal secretions. What is interesting, at least in the short data, is that at least males that were affected early on with COVID, looking at them serially, their sperm has done reasonably well. Most of the really bad sperm level cases in COVID infections are in people who we didn't really know what their baseline was, right? Because it was all happening so quickly. Mm-hmm. So they may have always had a pre-existing low sperm count. But, now that we're looking at people 6, 12, 18 months out, we're not seeing significant effects of the ejaculate and on sperm. Okay. Certainly not something that's non-recoverable. On the egg side, again, we have found viral particles in vaginal secretions. And so again, the question even is this a sexually transmitted condition? Problem is that when you're testing people for droplets, because when people are trying to conceive, they're getting close to each other, and the droplet contact might be what's seeding the person, meaning it's them breathing into each other's face or being within 2 meters of one another that's shedding the particles, not going through the reproductive tract. Okay. So yeah, there probably is systemic viral particle, mm-hmm. but I don't think it's getting to a point where it's actually meaningfully affecting the ability to conceive. But what may affect them is if they're so scared or fearful of next steps and delaying conception, that will probably have much more impact. The reproductive clock ticking while they're waiting for some sign.
Of course, and every month that goes by in the reproductive years, especially if you've been struggling to conceive, is a challenge. It adds more, 6 and 8 and 12 months later, it can definitely have an effect on your fertility and chances of conception.
Well, that's also a very interesting area, which is, again, this all spins out of the vaccine because we believe the vaccine is what will allow us to move forward with more confidence. But look, if you look at the psychosocial literature, those, even though we know from a reproductive perspective, 1 or 2 months of delay should not affect someone's overall prognosis, whatever it was at the start of that 2-month period. It should be pretty similar thereafter, all things being equal. But the psychosocial impact, and this literature is just developing, and I'm sure the vaccine is going to further challenge that. Many have compared the fear of COVID and the fear of a pandemic to that of death or loss. Like it is very, very fearful and significant, and to the depth of any significant clinical depression or clinical anxiety. So I unfortunately, I think we have to give people some solution or some way forward, because they just can't stay in that state. I mean, it's not tenable.
Absolutely. So we are going to move into some questions from patients, but before we do that,
okay,
are there pieces that we haven't touched on that you think that are really important to talk about before we move in there?
Well, I think that so another important area is, okay, let's say I choose to get vaccinated. Like, let's say we get some data and I want to. Well, if I'm not pregnant yet, do I have to wait? Like, what's the waiting period? Is it 1 month, 2 months? So most of these vaccine protocols are double doses. So you have to get a dose, and 3 or 4 weeks later, a second, like a little mini booster dose. And we don't know how long you have to wait, right? So is it 1, 2, 3 months? So I suspect there will be some waiting period that's recommended. Each monograph for the virus is different. So there's that consideration.
And what's the waiting period for? Just so we all understand, you wait for you have your booster and then you wait. We don't know what that waiting period is. What is the purpose of the waiting period? Or do we know?
I'm not an immunologist, but just from basic medicine, it's providing a vaccine. It's sort of like you're priming the pump in a way. You're getting the immune system to respond, and not all immune responses are the same for a certain amount of stimulus. And so I suspect the delay may be part of that. Also to check for adverse reactions. So if you gave someone like a whopping dose at one point, so the immune system it's still a biological process. It requires time to respond, and then the effect can wax and wane. So that's why some immunization schedules, as you know, some immunization schedules you receive when you're younger and you never receive a booster again. Some of them you receive a booster every 5 to 10 years. And with each vaccination campaign, like the HPV vaccine campaign had a certain schedule, and it's all the nuances of those immune responses. So the immune system, although we talk about it as this one big, amorphous space, it has nuance. Each response is a little bit different, and those boosters provide that difference. So through the studies, they realized that kind of and by the way, each company has a different gap. So the Pfizer gap is either 3 or 4 weeks, and the Moderna gap is about 3 or 4 weeks.
Okay.
So and whoever the providers will have to read the monograph and decide when to bring it back.
But that makes sense. Okay, thank you for that. I just wanted to clear that up so we understood. Okay, the questions are rolling in.
Sure.
So if you've got questions, please put them in the chat option if you're on Zoom, or in the comment section on Facebook. Is the vaccine safe prior to getting pregnant or during pregnancy? Is it advised not to get the vaccine until after the pregnancy is finished?
Right. So that's a great question. So just to reframe that, is it something that is safe to be taken pre-conception, during conception, or many people provide lactation or breastfeeding? So there's concerns at each step, right? So the preconception step is, okay, if I get this vaccine, will it affect my early pregnancy if it's still not fully in my system, or if my system hasn't fully developed immunity? Will it cause some kind of fetal malformation or embryo malformation? And the good news is that all of the data suggests that the type of technology that it's based on should not do that. So probably if you're going to get vaccinated, that would be the safest time, because you could always choose to delay pregnancy by a couple of months. So you would take advantage of that waiting time. Maybe you would get your diagnostic testing. That certainly wouldn't cause any harm. I think that the big kicker is during pregnancy, because those women, those specific women, were excluded from all trials formally. So I would say that on the safety scale, even though the Americans suggest it's safe and the Canadians have not promoted that, I would think that's the area that we're still really concerned about. And as a provider, I would have to make sure that you are really at high risk of COVID to reap the benefit. So I would be very cautious with that.
Okay.
And then finally, on the back end, you said when you're actually breastfeeding, well, then there's two people involved, right? There's you and your baby. Is there any issue? Because all the vaccination studies were in children 16 years or older, children, teenagers. So that's another group that hasn't really been looked at closely. And I think some of these are norms for vaccine trials. That's just the way they do them. And in some ways it's very discriminatory, but there's obviously a reason for it. So the answer is, I would have to pick of the three options. Obviously, preconception would be probably the safest, and then the other two are
taking
tied.
these conversations back to your physician, to your fertility specialist, to make sure you are informed and feel comfortable with whatever decision you do make.
Yeah, exactly. But I think the conversation, everything we speak about tonight, is subject to your own physician. I mean, for example, the same response I'm giving if you were someone that was more high risk, or let's say you were overweight, hypertensive, diabetic, had some other respiratory or cardiac problem, like heart or lung problem, well, we might say to you, you know what, even though we don't know so much about COVID vaccine, we're really worried that you're at risk of something bad happening from COVID. So we'll take the risk. The vaccine is more helpful. So that's something that has to be individualized with your primary provider.
Okay, great. Are there any clinical studies on the effects of sperm and egg health or production?
Right. So there actually are some studies that have looked at small studies, like a couple dozen people. We looked at it, our group at Create did a a comprehensive review looking at all those areas. And it looks like we see the virus in sperm. There's actually males that have complained of a bit of an orchitis or testicular discomfort during their COVID, and it was they found virus there, but the sperm levels didn't seem to be irreversibly affected. So that's on the sperm side. And certainly in eggs, well, it's more difficult to look at eggs because they're much further away. So because we don't have the equivalent on the female side of a semen analysis, but we can look at the reproductive tract through vaginal secretions, and those have shown virus. But again, how transmissible is that? We don't know. In other areas, there has not been one case in the world so far over the last year of COVID-19 transmitting through cryopreservation tanks, like through the egg freezing or the sperm freezing or through the embryos. So that's very reassuring. I almost said HIV, but because that's the same kind of conversation we have. But this virus obviously needs to live somewhere, and it doesn't live inside the sperm or the egg cells, or if it does, it can't survive there. So fortunately, we haven't seen any transmission in that group.
Okay, that's great. That's really great information. Do we know if there are any long-term risks to, I'm not sure if this is the vaccine or from COVID. It's not clear in the question. So how do you determine the long-term risks, or how do you know if there are or would be any long-term risks? I'm assuming it's for the vaccine because this is what we're talking about. Right.
So, I mean, when you look, vaccine, the concept of we can talk about both. We can talk about long-term risk of vaccine and long-term risk of COVID, because those are really the two things you have to compare, right? I mean, if there's really no significant long-term risk to COVID and really isn't as bad as some people are saying, then why do I have to bother with a vaccine? So we do. So let's talk about COVID first. So we know COVID can have long-term morbidity. Mortality obviously is that happens, but at a less common rate. But the long-term morbidity for COVID can be quite significant in some individuals. I mean, there have been many populations, all the way from the fine-tuned athlete to just regular people that have had chronic respiratory problems, generalized fatigue. I mean, the symptomatology of COVID is from head to toe. I mean, everything from smell changes to headache to myalgia, but some people have had ongoing respiratory capacity issues. So, I think there are some significant long-term risk. But in terms of vaccine, well, again, even though we've had the COVID vaccine for a short period of time, we've had coronavirus type vaccines before,
Yeah.
and we've had vaccines in general for many, many, many decades. And so from those vaccines, we're seeing that the adverse effects, both short and long term, are quite small. I mean, certainly there can be some neurologic effects, like you may have heard of people getting like a Guillain-Barré or some kind of paralysis of the nerve. That's one of the more common things. But for the most part, that's what's so great about vaccination, is that the only real risk long term is that it'll wear off and you'll get exposed to the condition again. But for the most part, it's quite a successful program.
Okay. I'm sorry, I apologize. I'm just kind of scrolling through the questions as they're coming through. Should we wait for our surrogate to get the vaccination before doing a frozen embryo transfer? So that's a great, you know, there's a third party here involved in this family building option.
Right. So obviously I'm going to start, I should just start every response with a little header, speak to your doctor, but this might actually be my own patient. So that's,
no, that's right.
That's a problem. But I think we have to look, we always treat the surrogate as an autonomous person. It's a pregnancy like any other in some regards. And so operating in Canada, we really currently can't offer her the vaccine at this time. Now that may change the next week or 2 weeks or 4 weeks, but your surrogate's going to be offered the same kind of PPE and social distancing that we all are doing. What would be challenging is if your surrogate was also a frontline healthcare worker.
Mm-hmm.
Now, that would make the question interesting for me. I would have to weigh that out. I mean, I think right now it is just too early to offer this vaccine, even though we all feel that it is the right thing to do. There are other vaccines that are given in pregnancy, right?
Yes.
There are many examples of that,
Mm-hmm.
and there's some that we don't. I suspect, my feeling is that the COVID vaccine will fall in, I mean, because it's a novel vaccine as well, will fall into the group that we will be able eventually to give to pregnant women, but not today.
Of course. So as a follow-up, this is a different individual who had written to us. My husband and I have been trying. However, we put that on hold as I'm a COVID nurse who is to receive the vaccine tomorrow. I have chosen to get the vaccine, but have been worried about it if I should continue trying or wait several months after the vaccine. Have also had concerns about the vaccine, if it's actually safe for women of childbearing age.
Right. Well, there's a few considerations there. I do agree. I think the safest thing to do is to take some kind of pause. Remember that even though the studies looked at tens of thousands of people across different viruses, different companies, it's still a relatively small group of people. I mean, until you launch this vaccine on a large group, that's really the power you need to see any significant adverse events. And you have to look at the right population, pregnant women. That being said, because of the 2 month or 3 months, I mean, that would usually be the max you'd have to wait. It wouldn't be more than that. I think the safest would be to wait, but you could do something constructive during that time. I mean, you could pursue fertility preservation during that time, because as we said, sort of egg freezing or embryo freezing, because there should be no theoretical risk to your egg, sperm, or embryo.
Right.
So if you're if you said you're with a partner, so I think engaging your provider and discussing embryo freezing would probably be most appropriate, because that's something that you're doing actively and in some ways sealing your pregnancy rate success for the future consideration.
Mm-hmm.
Unfortunately, that still is not under, at least in our province, not considered a fundable service. So it would be a non-funded service.
Mm-hmm.
I'm not sure about PEI or Quebec. Certainly some provinces it is not. Perhaps there's some compassionate medication, compassionate support that could be accessed. So that's how I would probably approach that one.
Mm-hmm.
That's what I would do.
Okay, that's great advice. And that's a challenge. I mean, when you're working as a frontline COVID nurse,
Right.
I mean, the risk of her being infected is quite high.
Yeah.
So
I think the other thing we have to realize with COVID is that when you look at the maternal fetal unit, there are other viruses that have been around in the media cycle in the last 5, 10, 15 years, where the burden either on the maternal side or on the fetal side, has been much more traumatic. For example, the best one is Zika. That's the classic one, where, I mean, I'm still meeting patients who describe delaying pregnancy during that time because they were living in a jurisdiction, of Zika, or where Zika risk was significant. And that is very devastating. I mean, the teratogenicity, the impact on the embryo fetus was quite profound. We are not seeing that in COVID.
Great.
So we have to realize that we vaccinate for many reasons. You pursue a family for many reasons, and a lot of it is aligned. But I think the good news about this COVID discussion is that if you were to make a misstep, right, like if you were to sort of over or under interpret the risk or safety of COVID vaccine, my sense is that at the end of the day, you probably would be fine, because we're living in a society that is providing PPE, that's distancing, and we're working with vaccines that are not the same as those other vaccines, and we're working with a virus that behaves a bit differently. So that's why all these statements, even the American statement, is really talking about weighing risk benefit to suggest that the risks and benefits both have merit. You know, it's not like they're coming out and saying the risk is so great that you just have to avoid this like the plague. So that for me that's why I find this conversation encouraging, because we're so on the right path, both on the society end and on the therapeutics end.
Great. Thank you for that. I think that that's really important to acknowledge. Okay, a question from Facebook. I'm 15 weeks in St. John's, Newfoundland. I'm a paramedic and we are currently being offered the vaccine. Wondering if the risk of exposure or illness outweighs the risk of the unknown side effects during pregnancy.
I feel like I'm in a corner.
I know.
There's a wall behind me. Well, I mean, you know, again, not to sound like a broken record, but in the U.S., if you were in the U.S., you would be offered the vaccine explicitly. In Canada, I think you've got two sources. Health Canada's have guidelines on this topic, and you have your local health authority. So the Maritimes, Newfoundland, Labrador will be. I mean, look, it's even a more interesting area, because how many people are on your team? I mean, there's probably so few paramedics, and if you're a specialized paramedic, like a higher level, like a tier 1 or a flight paramedic, the risk of you not doing your job is so much greater, and the exposure is so high. So I think this is a conversation that is probably tomorrow morning you're calling your physician or your HR and exploring what the advice would be.
Great, that's great advice. Will, this is a great question. Will my baby be considered vaccinated in vitro if I get the vaccine while pregnant?
Right. So there's no question that their antibodies do travel from the mom to baby. So there will be some possible passive immunity, but it won't be sustainable.
Okay.
Right. Meaning, so you need to have that ability to make those antibodies. And so we do know that antibodies can cross the placenta. And so there would be that possible benefit, but passive immunity, and that's in fact another reason why you get those boosters, is because the active immunity takes time to build up. And you know, if you've seen when people get allergy shots, like the immune system does take time to do its job. So I know that would not be considered vaccination for your embryo or for your baby. First, for the embryo, for sure not, because they don't have an immune system that's functioning, and for the baby, early baby as well, because their immune system is still developing a few years ex utero. So no, it's a good thought. I mean, it would be nice, but that's not going to work.
Okay. Will fertility clinics in Canada be requiring fertility patients to have the COVID vaccine prior to treatment?
Well, I think one day, just like we do serology for all of our, varicella and for hepatitis B and for anything that's able to be vaccinated. I mean, some conditions don't have a vaccine, like HIV or Hep C. So because we were able to develop this vaccine so close, I think at some point it will become part of our preconception evaluation. Or just like in my practice, when I identify people that are missing one of the vaccine titers or require a booster, we pause therapy. We say, please go get your tetanus booster, your measles, or whichever one you need, and then delay pregnancy by 30 to 60 days and then come back. So
Okay.
yes, ultimately COVID will become like that unless COVID goes away, which I don't think it will. But to get from where we are now to there are quite a few steps,
Mm-hmm.
and obviously safety studies, and our government has to, our health agency has to actually formally accept it as an option for pregnant women, which it has not done yet.
Absolutely. Great. Thank you for that. Um, will the vaccine affect the odds of conceiving with fertility treatment or interact with fertility medication?
So the COVID vaccine does not cause infertility. Full stop. Right? That
Thank
is
you.
a misconception. I don't want to get into the fake news about that, but there is one of the spike proteins sounds a lot like, or has homology or looks a lot like one of the placental proteins, but they are vastly different. Okay, the vaccine does not cause infertility. I'm not sure how many times I can repeat that. It doesn't. All right,
Thank you.
and you might say, well, how do you know? It's only been a year. Again, back to the point of the mechanisms, the way it was generated, the way it's developed, it does not do that. And so what was the second question there? I missed that.
Oh, sorry.
Will it cause infertility?
Sorry, I just, and it,
Okay.
will it interact with fertility medication?
Oh, okay. Absolutely not. I mean, that's not how it works. Fertility medications, and there are different types of fertility medications,
Mm-hmm.
but they all have unique mechanisms from the way a vaccine works. I think the only fertility medication, sometimes some fertility patients are on some steroid. So maybe the steroids could interact potentially. But again, I think if you're going through a vaccination program, there's probably going to be some kind of amount of time that shoulders your treatment, like that gaps it.
Mm-hmm.
But those things are independent.
Okay.
What I think is also interesting though, and again, this is the whole overlap of approach, because right now we've been using social distancing, PPE, and sort of societal, sort of what I call like old style, old world measurements to protect us, right? Hand washing, nothing really fancy. And let's call the vaccine like high tech, sort of COVID 2.0 in terms of the therapy. And then we've been dealing with all the sick people in the hospital with advanced technology. So the way the fertility clinic looks is not going to change for quite a while. In fact, the way society runs is not going to change.
Mm-hmm.
And we know that there will be lockdowns and various restrictions for months to come. In fact, I wouldn't be surprised if after the Christmas New Year break, we have a modified schedule that goes on for quite a few months, because we just don't have, like, there's that overlap of the time to vaccinate everybody, the rollout of the vaccine, and having enough people in a safe position. I mean, you need about 70 to 80% of the population vaccinated to feel comfortable.
Yeah.
And that's being optimistic. It was very interesting, actually. Because this is something that we all listen to. So there's some really interesting podcasts on the rollout of the vaccine, like how they actually sequestered UPS and FedEx and all like the marshals around, like how they protect the vaccine, both on the American and the Canadian side, and just the amount of dry ice that you need to house all of these vaccinations. In
Mm-hmm.
fact, I think it was either FedEx or UPS purchased a dry ice production factory just to supply enough for one of the vaccines. So, they can only be rolled out. You can only produce so much vaccine. So we do need to be ready for these social distancing measures to be around for quite a while.
For a bit of time.
Yeah.
Great. Thank you for addressing that. I think that's, when we set expectations, it's easier to go through with them, or accept them, and until, life can start to look a little different, a little more like it used to be.
Yeah, I think life. We talk about the new reality, and I do feel that there are certain parts of at least medical care, because I can't speak for other sectors,
Mm-hmm.
but certainly from a medical care perspective, I think the virtual bug has caught quite a few of us, and I think that it's sort of in some ways been a bit of an evolutionary push to
Mm-hmm.
move to virtual telemedicine,
Agreed.
even though we've been adopting it slowly for quite a few years, more as an outreach maneuver. Now it was sort of in a desperate mode, but I think it's really, on balance, been very comfortable for most people. So again, I don't want to speak about other sectors, but I know from speaking to friends and family and colleagues and patients that work in other areas that there's a comfort of working apart, even though it's socially distant. I don't think the fertility clinic is going to look any different for quite a while, if
Yeah,
ever.
of course.
Yeah.
Well, and telemedicine has also increased access to
Mhm.
care for patients, especially in Canada, where our geography is quite vast. And patients in Thunder Bay don't have access to a clinic down the street and need to travel for many hours to get to Toronto or Ottawa or Manitoba for treatment. So being able to have an initial appointment with a physician to get some of that workup done, has opened a lot of doors, and I'm excited from the patient perspective to have that access,
Mhm.
increased access to care and fertility specialists, especially.
Absolutely. Not only that, but initially, at least a few years ago before COVID, the teleconsult was sort of in isolation. It was just the consult
Mhm.
part, and there was all these challenges of how to move people down to the clinic. But because everyone's now in this situation, those pathways, those clinical pathways, have become more established, and they're no longer just one-offs.
Exactly.
We're doing more and more outreach and trying to help more people. And you're right, the person from Thunder Bay is just as close or as far away as the person from Thornhill or Vaughan, at least in my
Right.
case, where I'm
Yeah,
working.
exactly. Does the vaccine, or do we know if the vaccine will affect birth control?
Again, I mean, it shouldn't. The vaccine, again, works through mRNA and, immune system. Birth control pill it can be affected by other drugs,
Mm-hmm.
but they're totally different classes of medication. So I don't believe it's been formally studied, but the biology wouldn't support it affecting birth control pill.
Okay, that's great. So I think those are I'm just doing a last scroll through here. Those are the major questions that have come through in the big topics. Have we missed anything? Anything patients need to consider? Or
Well,
maybe let's talk about a few sort of final thoughts for patients to take with them.
well, I think one of the final thoughts is that we're closer, but when you get close to something, sometimes if you get too close to it, it also is a little bit fuzzy. Like you
Mm-hmm.
have to if something's in the distance, you take a few steps forward to put it into view, and then you take a few steps forward to actually see it even more closely. But if you take too many steps, you're right up against it and it's hard to reach. So you have to actually move backward, kind of like what I'm doing in the screen right now. I think that's kind of how we're at. I think that's where we are with the vaccine, which is that we went right up close and we need to move back just a little bit and figure out, okay, we're many steps ahead of where we were a year ago. We're ahead of schedule as far as we're concerned from a
Mm-hmm.
virology perspective, but are we actually, is this the best practice? And
Right.
it might be, but we can't afford to make a mistake. So I would say that for patients, especially our population here, our audience, you're asking all the right questions. You may need to wait a little bit longer to get your final answer. You might have to wear a mask for a little bit longer. But I guess the good news is everyone's going to be wearing a mask for a little bit longer too.
Mm-hmm.
What's confusing for me are the joint statements,
Mm-hmm.
meaning it's one thing if the American Society says one thing and the European Society says one thing and the Canadian, but we were talking about this earlier today, that there was a joint statement where there was actually a Canadian organization, CanSage, which is one of the uh, societies for excellence in gynecology, and they came out on the side of the Americans. So that might be confusing. So I have to talk to my CanSage colleagues and find out what exactly they mean when they say that they're promoting the vaccine.
Mm-hmm. In
And what
pregnancy, you mean, or for pregnancy? Yes.
in
Mm-hmm.
pregnancy, in the reproductive age
Mm-hmm.
female who's pregnant or trying to get pregnant. But what I do know for sure that this is on the top of everyone's mind, and you won't be holding on too long for answers, because I suspect that in a couple
This is
weeks or a
changing.
month, it's going to change, and we're probably
Yeah.
going to have this talk again, either with
Yeah.
myself or a colleague.
Absolutely.
But
So for all of you watching, just so you know, Fertility Matters is working very closely with our medical specialists to stay on top of this information. We will be releasing our own statement very shortly, and we're going to be linking the information from the Canadian Infertility and Andrology Society, which is the overarching body for fertility experts in Canada, Health Canada, and we will link those to the ASRM, which is the American Society for Reproductive Medicine, and the other American links for you to read so that you have that information. And we will continue to monitor and stay up to date. And if there are any changes, you will hear from us about those from us first. We will come right back here with either Dr. Baratz or another fertility specialist to ensure you have the information you need to help make these educated decisions.
Okay. Yeah, so my final point would be, I just want to wish everyone a healthy, happy, safe, and peaceful holiday season and new year, and that this is the wrong time to put our guard down. I think this is a very special time, but dangerous time, and that I urge everyone to follow their jurisdiction. Yes, all of the holiday time is a special time to be with family, but if they're going to become sick or if we're going to become vectors, it's not going to help. And that's beyond just the pregnant female, or the other person trying. But we're in this together, and we're getting closer. And I'm happy to field any questions after this session. Carolyn, you'll forward them to me.
I will.
So that's my final thought. Do you have any other final questions? Or
no, that's it. I mean, the questions that have come in were incredibly thoughtful, and you can see that there is, we can understand from the fertility patient perspective, especially, or for those who are pregnant, what do I do? What is the best choice? And so collect the information, speak to your physician, your primary care physician, your obstetrician, your fertility specialist, to help you make the decisions that are right and effective for you as an individual. Thank you so much, Dr. Baratz. It's always a pleasure. And for all of you who joined us live, thank you so much. If you're watching the replay, we appreciate you coming to Fertility Matters as your premier voice of fertility patient support in Canada. And just a reminder that Fertility Matters Canada is a registered Canadian charity. And in this time of giving, if you're able, please consider making a donation to our charity. And we'll visit you again after the new year for another session of Figuring Out Fertility. Thank you, Ari. Have a wonderful new year.
You too. Bye-bye.
Bye.
Good night.